Good afternoon, everyone, and welcome to the Longevity Center webinar. And I'm Dr. Linda Ercoli, and I'm the interim director of the Longevity Center at UCLA. And we're just giving a little bit more time for people to grab, to get online, and we'll be starting in just a minute. Okay, it's about 5 after 4, so I think we can get started. And what we're going to do is I'm going to talk a little bit about our topic today, which is the impact of health disparities on cognitive aging. And then we'll probably save the Q&A till the end, only because I'm not a good multitasker. So that's my transparent reason. So without further ado, I very much am proud and delighted to introduce our speaker and guest today, who's Dr. Paola Suarez. Now, Dr. Suarez is a bilingual, bicultural neuropsychologist who is a clinical assistant professor of psychiatry and biobehavioral sciences at UCLA's Psychiatry and Behavioral Sciences Department. So she has been the co-director of the Cultural Neuropsychology Program within the Hispanic Neuropsychiatric Center of Excellence for the past 2 years. She previously served as the Associate Director of the Cultural Neuropsychology Initiative. Dr. Suarez completed both her internship and her fellowship at UCLA, where she focused her training in cultural neuropsychology, serving the Latino population of the greater LA area. Now also, Dr. Suarez's area of interest lies in the intersection of research and clinical work with bilingual patients. So she completed her dissertation on this topic at the San Diego State University and UC San Diego Joint Doctoral Program, where she worked with Dr. Mariana Cherner at the HIV Neurobehavioral Research Program. And she has served as the chair of the Culture and Diversity Committee of the National Academy of Neuropsychology for the past 3 years. I'm going to add something to your bio, Dr. Suarez, which is I believe you have pretty much invented the area of culturally responsible neuropsychology as well. So, welcome, Dr. Suarez.
Thank you for such a kind introduction. You definitely have, I feel like, set up the expectations really, really high with that bio, and I hope that that I can live up to it. So thank you. Thank you for the invitation, Dr. Ercoli.
Thank you. Well, it's really important to have you here for this very timely and important topic. I'd like to start by actually discussing and defining what health disparities are. I mean, we hear that term a lot now, much more than we did, in the past. It's been an area of research for really quite a long time, but I think it's becoming more in the public eye recently. And I would really like to hear, your definition of what health disparities are and some examples of what they are for people living in, the community.
Okay, so I think I want to start by saying that this was it's been a journey since the COVID pandemic hit, and I'll explain a little bit more why I'm saying that. I have had to, in many ways, do a little bit of reverse learning, if that's even a term. I just made that up, because all of the work that I have been doing since I started doing any work in neuropsychology has been in the areas of disparities, kind of mitigating those disparities, but not necessarily enter the field thinking about health disparities as a field or as an area of study. It was just because I was working in the HIV field for many years, and HIV, as we know, disproportionately impacts community of color, particularly African American and Latino communities. And the work that I've been doing in providing services for Latinos has been, again, clinically about health disparities and inequities, not necessarily putting a name to it. Let's just put it that way.
Mhm.
So more recently, during the COVID pandemic, I have had the honor, the privilege to teach health promoters of the Spanish-speaking community about exactly this, about what are health inequities, how do health inequities look in the Latino community more specifically. And it's impossible to look at the Latino health disparities and without looking at the literature and not seeing the disparities also about African Americans and the Native Americans.
Right.
So what I'm saying is that while the work that I have been doing is all in health disparities, this type of format and this conversation is something that it's new for me in this sense and exciting. And I've been doing a lot of reading to make the topic, to do the topic justice. And so one of the definitions that I read about health disparities said health disparities just refers to a burden of illness, injury, disability, or mortality experienced by one group relative to another, okay? These disparities typically affect groups of people that have been systematically excluded and discriminated against based on race, ethnicity, gender, age. Gender is a big one within the Latino disparities, gender is a big one. Sexual orientation. So any group that has been systematically excluded, systematically discriminated, and they end up with higher rates of injury, mortality, disease, that's health disparities. Whenever we talk about health disparities, I would like to say it's important to think about the intersection of race and socioeconomic status, in that health disparities are tightly connected, right, to socioeconomic status, right? People having worse outcomes in the lower SES, lower socioeconomic status groups. And as we all know, people of color are overrepresented in those lower SES groups, and those overrepresentations in those groups are because systematic oppression and discrimination, not of our own fault. And the second question was about some examples of those disparities. I think it's impossible to not mention COVID, right? We're in the middle of COVID pandemic, and while we all knew that disparities existed, this virus really came to highlight these disparities more so than we could have ever imagined, or that some of us knew, but maybe it was hard to describe, like, right? So there's no reason for the virus to be affecting communities of color, right? We know that Latino communities and African Americans are disproportionately impacted by COVID, and those are because of systemic issues, right? Like lower testing in communities of color, hospitals where we're over represented have less PPEs, they have less resources. And so we also are, at least we've been talking to the community a lot and explaining the people of color are the ones who are actually putting their faces on this pandemic. They're out working. They're not behind a computer like some of us can in academia or in other professions. They really are just in the supermarkets. They're doing the job that a lot of us are not. And so those are systemic issues that lead to health disparities. COVID is a big one. And since we're in the topic today of cognition, I'm afraid that this disparities in rates of infection in COVID and death and mortality for people who are surviving with COVID and are sicker because our people of color also getting sicker with COVID, that we're going to see the effects of COVID on the brain for a long time to come.
Right, and even before COVID, I think you're right. COVID has affected, has brought things to the surface in a very loud way, right? That shows these disparities in infection rates and death rates, particularly in people of color, right? Disproportionately speaking. But these disparities have been there. They've always been there. And I was thinking about, some of the disparities that we experience, like in just getting diagnosed with a cognitive disorder, for example, because we know that it takes longer or in minorities to get diagnosed. They come to diagnosis when their dementia is more advanced, for example, than non-Hispanic whites. Disparities in treatment, right? So we know in dementia research that people of color are not treated with cholinesterase inhibitors as frequently, again, as non-Hispanic whites. So there are disparities basically in services, right? There are disparities in knowledge and getting educated about dementia and cognitive functions in aging. And then there are disparities in overall healthcare and access to healthcare that have downstream effects on cognition.
Absolutely. So pre-COVID, since we're talking about cognition, it's important to highlight some of those disparities, right? So Latinos, for example, are 10% more likely to have a cerebrovascular accident, 24% more likely to be obese, high blood pressure, 23% more likely to have blood pressure. The most striking health disparity, though, and it is most significant for Latino, but I've read that it's also true for African-American populations, it's really the disproportionate rate of diabetes that exists among Latino patients or populations, like 63% more likely to have diabetes, somebody of Latino descent, that's somebody who's white, right? That's like, to me, it's staggering, especially because we know the impact that diabetes has on day-to-day cognition. When our sugar levels are up, they're down, people feel like they're foggy, a little bit maybe disoriented. We see patients who a lot of the times maybe fall asleep on public transportation because their sugar levels were impacted. And so diabetes is a big one. I was actually reading as well that among people who are 70 and 74 who are Latino, 50% of that population suffers from diabetes. So you're right, there was a lot of illnesses and disparities that existed prior to COVID-19 that then lead to more cognitive disparities. And in fact, cognitive disability is almost twice as likely high among Latino communities than white counterparts.
Yeah, similarly, African-American community, depending on the studies that you read, about twice as high the prevalence or the incidence of Alzheimer's disease and dementia, and African-Americans compared to non-Hispanic whites. So we're, again, what are some of the sources or the reasons for disparities? What are the, how do they come about? Why do we have them? Why do some people have them more than others, right? That's the idea of a disparity. But what is it that puts certain people at such disadvantage?
I like this quote that I read that says that health is political, right? And there's whole areas in academics dedicated to that. But some of the usual suspects, I would say, among Latinos are, you mentioned one of them, insurance, access to insurance and to appropriate healthcare, obviously. So before the Affordable Care Act, about 40% of Latinos were uninsured. That has dropped to about 20%. So that's a huge, right? So that's a political, that health is political. Now 20% more Latinos have insurance. The rates are down to 20%. We know, especially among African-American communities, there's historical discrimination, underserved, people of color being used and abused, right, in experiments that, which is why we're now having a lot of the skepticism about the vaccine, where people really have been discriminated. There's been really terrible theories about inferiority. It's just led to a lot. There's been a lot of historical discrimination in health that has led to people not to trust the healthcare system. That's one reason. As well, among Latinos, a big one is immigration policy, especially in the last years, has been very particularly stressful and hard for Latino communities with the immigration policies. There's a lot of talk about social vulnerabilities, right, that lead to health disparities and inequities, which are determined or defined as all the factors related to health inequities, and refers to accumulation of negative factors that affects us throughout life. One example that comes to mind, I was talking to my friend and colleague earlier, one example that comes to mind, for example, in social vulnerabilities is pollution in some areas of town that lead to health disparities and to disparities in cognition. There's a whole area here in East LA where a tragic event happened. I don't know if everybody knows about this company that disposed all their battery toxins in East LA, and it's led to an enormous toxic disposal in the land where kids are playing, where families are eating and walking, and so those are right, like pollutants, things that have to do with social vulnerabilities where people live. That again is not to their own fault, just it's related to the socio-political situation in which we're in. I would say this is a long answer. I'm sorry, but there's just so much, and I think it's important to mention that one of the things that also I've come to learn in Latinos that leads to some of the disparities, especially in cognition. Like I was thinking about the rates of Alzheimer's being much higher, like 1.5 higher for Latinos than for white counterparts. I don't know if you have heard about the Hispanic paradox in medicine, but it's the idea that while Latinos were living sicker with less health, lower SES, we experience discrimination, we're living longer. We live longer than other groups, even than whites. And so, of course, if we're living longer sicker, we're living longer to ages where Alzheimer's are at the rates of like 50%, right? When you enter kind of 85 years old, and we are living to that age. That also leads to those higher rates of disproportionate impact on cognitive diagnosis. Language, I think it's a huge one, especially in Latinos, right? If we don't have doctors who speak our language, it's very, very hard to get services. Latinos are more likely to get services in primary care as opposed to by their specialties. So I had a patient the other day who told me that for 2 years, his primary care told him he had anxiety because he had like a tremor. 2 years, and he was finally diagnosed with Parkinson's. But about 2 years ago was the first time he had gone to the PCP, but he started experiencing symptoms prior. So there goes that. There's like getting care at the primary care physician. And so language, there's studies that say that even if a bilingual person like me, that if I go to the doctor, my experience of talking to a physician who speaks English is very different than in talking to a physician who speaks Spanish. And I would spend more, I would be more satisfied, let's put it that way, or feel like I'm treated better by a physician who speaks Spanish. And with lower SES and the historical kind of systems of oppression here that exists for a lot of immigrants and in general in people of color, leads to lower education and health literacy. And like I said, among Latinos, women are more affected in general across many different diseases for reasons that again have to do with discrimination and oppression.
I think when we're talking about health disparities, you know, we're not, like you mentioned something very important, lifelong. And these are problems that have been, you know, in this country, really going back to the point of origin of this country for African Americans, right, with slavery and then followed by Jim Crow. And so like these health disparities have been in place for one reason or another for, you know, hundreds of years. And though things have gotten better, of course, but they're still there. There are still many inequities and barriers and unequal access to care. And one of the things that really has been a topic of intense research has been something called allostatic load. And it's really about the effects of chronic stress on the physiology, on multiple systems of physiology in people. And so the chronic stressors that, in essence, what they do is they affect, you have these high levels of stress hormones that are released in response to perceived stress. So this perceived stress could be anything from poverty, discrimination, living in, you know, violent, dangerous neighborhoods, hunger, chronic, you know, childhood poverty as well. And that it's this chronic stress that leads to dysregulation and leads to physiological changes like hypertension, metabolic syndromes like diabetes, you know, over time, right? We're looking at over time, cardiovascular problems, immune system dysfunction, that in turn lead to disease. And so there have been many studies that make this connection, that it's not just, you know, yes, people do have genetic predispositions. There's that's involved in that. There's also behavior, but some of these behaviors are also related to the stress, right? Whether you don't have a good diet, maybe it's because there's poverty, or you're stressed because you have depression related to your situation, and so you drink. And it's just like a many-layered problem that over time leads to these changes in cardiovascular, among other things, and metabolic that have effects on the brain. So we know that people with, you know, stroke, with diabetes, with heart problems, have cognitive problems, or they're at increased risk for cognitive problems. So it really is a pretty complex problem that develops over a lifetime. And, you know, what can we do to offset these risks for people? Because it's a here and now problem. What can we do to help people now, you know?
I'm going to answer that question, Dr. Ercoli, in a second, but along those lines, my favorite researchers actually happens to be here at UCLA, and he studies epigenetics, right? The interaction of genes with environment. And I started looking at his research and learn just a little bit about it. I just like to go hear him talk. It's not my area of expertise, but I've always been interested in sociology and the intersection of sociology and the brain. And I heard about this research there, and I looked it up again to see what's been the most recent on telomeres. So telomeres are markers of cellular aging. So to your point that this is not just all perceived, that it's not just esoteric, that these are experiences that have real consequences on the body. So they've measured telomeres, and they found out that telomeres, which is again, it's a marker of cellular aging, is sensitive to the effects of stress, and also leads to premature aging. And this study that I read, the results suggest, and I'm going to read, that multiple levels of racism, including interpersonal experiences of racial discrimination and internalization of negative racial bias, operate jointly to accelerate biological aging among African American men. So again, these are real life experiences that people are going through that are impacting their health. It's like shrinking almost life. And so it's like real life effects. And I think that the answer to the question of what can we do if we had a magical wand would be to change the social structures that lead to all of this, to all of these inequities, right? To all of this social determinants of health that then lead to health inequities, right? We would work towards improving health equity, right? We would work towards avoiding these unnecessary, unfair, and unjust distribution of this social determinants, right? Economic resources. We would make sure that things are that we're distributed equally, that we do something to level the playing field, because the playing field is obviously not leveled. And I'd like to actually mention that we talk a lot about inequities and about people who are being disproportionately affected. But I started trying to introduce the idea every time I give a talk like this, that while there's a group of people that are being disproportionately affected, there's a group of people that are being disproportionately favored, right? So I have a colleague that now directs a heart transplant service in another university, but he used to tell us the story how white, more affluent patients died at the same rate as other patients of color, but for very different reasons. That in many ways, it was the white patients were overtreated. They had so much access to care that they ended up getting procedures that maybe they didn't need, whereas the patients of color would get to the heart transplant unit much later and were not on time to get their heart transplant, and their death rates were the same, but the reasons behind those were very different. So to that, I'm just saying, I just wanted to like make the point again that while some people are disproportionately not given much, other people are disproportionately given too much, right? Some of the things then I think, because I don't have my magic wand yet, I think we need to advocate at the local level, right? Like we need to advocate. There's plenty of research to suggest that having a physician who looks like you, who can understand your culture, who can understand maybe how your disease might interact with your family or vice versa, then that goes a long ways, right? So advocate for representation for diverse physicians and psychologists, in even like staff. It's everybody to advocate for that. We need more providers that speak Spanish. If we're talking about the Latino community, we need more providers that speak Spanish. And I would like to actually say that as providers, if we are providers, or in general, we need to approach issues or health issues with a lot of cultural humility, right? I think that we, for example, for the Latino community, it's important that we recognize that not not a one size. What is the saying? One shoe fits all. I'm
One
like
size fits
butchering
all.
the saying.
Yeah.
That. Thank you for helping with my. That we're not all the same. We're not a homogeneous group. I am a neuropsychologist, but I am very interested, like I said, in issues of social inequities in politics. And I mean, the election right now just showed us that Hispanics are a very heterogeneous group. So we need to start by recognizing that the needs or the ailments or the risk factors or the health inequities here in California for Latinos might look very different than in Florida. We're a very different population. We have different immigration patterns, different levels of education, and that it think that the same might be for Native Americans who reside in California versus in the Midwest. To think that maybe the experience of Black communities is different in California that it might be in the South that it is, right? So we need to kind of take a step back and first not cover everybody with the same blanket because we all have different needs. So some dose of cultural community to improve like cultural congruence in the patients.
Right.
To educate communities about cognitive health, that's a huge one. And we have that opportunity doing things like we're doing right now. That's something that we can do that's tangible. We're not going to be able to solve the magic wand in a while, but we can start by educating people.
Oh, I'm sorry. Go ahead.
No, go ahead.
Education is very, very important. And it's one of those factors that in health disparities is like a basic factor in leading to greater disparities down the line. So like if people don't have a good quality of education, not necessarily just years, right? But a good quality of education in younger age, it affects so much down the line. It affects the job you have. It affects the lifestyle you live. It affects, do you get health care? Or do you take a job that typically doesn't supply health care? And so that education is really key because I think people who get educated tend to get more educated and have, you know, the curiosity or kind of like that meta knowledge that says, you know, I need to get out there and really avail myself of information, right? So you're talking about education and information and the importance, whether it be COVID or whether it be heart disease or stroke, of people getting educated about it. And the other thing that you mentioned that's really important is getting educated in your community. So a prime example has been COVID, because the risk factor for LA is different, right? COVID risk than the risk in Montana. You know, so when you're looking at national averages, it mishmashes that together. So it's really important that people say, what's my COVID risk in my neighborhood?
Mm-hmm.
And you know, same thing. What does my local Alzheimer's Association say about my risk for dementia because my mom had memory problems? So you're really on spot on by saying that people, we need to go out and educate people. We need to make education accessible to people. Like people need to know we exist, or they need to have doctors that are close by them in their communities that are accessible. So that's really important.
Yeah, absolutely. Because to your point, Dr. Ercoli, that years of education, right? Like your own education. And I was actually, I'm not going to get lost in that, but maybe if somebody asks a question about education, I'll say what I was going to say about actually how education is not different. It's not all the same, that even in people who are educated, there's still disparities within that. But as far as cognitive health, but you were connecting, I think, education with health literacy, which is so important about.
Thank you. Yes.
Decisions for yourself or your loved ones. I was going to tell you an anecdote that a couple of weeks ago, since the pandemic hit, we've been asked to educate the Spanish-speaking community through the Promotores Health Network, which is a network through the Department of Mental Health of community members who work for the department. They're members of the community and they educate members of their own communities about different issues in health. They're a preventative network, which is something that also leads to health disparities. We don't have enough preventive medicine and preventive education in communities of color. So they're trying to meet that need. And we were given a talk on COVID-19 in the brain and the potential effects of COVID-19 in the brain. And I'm like 15 minutes into the talk and somebody raises their hand and says, Doctora, can you explain what cognition means? What's cognition? Talk about cultural humility or lack thereof on my part to assume that my community understands what cognition is. It seems like something, so, oh, we just throw the word out there. And so I took a step back and I was like, oh, okay. So we need to start there. We need to start talking to people even about what cognition is, what the brain does. And so I think that's huge and that's something that's tangible. I'm encouraged a little bit by what's happened this year, I think, in institutions and in general. UCLA just rolled out their vaccine plan. And they're actually going to use the social vulnerability factor to educate their vaccine plan. And that's huge. So again, those are some tangibles. We do not have the magic wand, which would make it so that we kind of reverse things so that we could improve resources and give more resources to hospitals where communities of color are. I heard on MSNBC the other night that somebody said, how should we distribute vaccines? And somebody suggested that we should actually, because communities of color are being disproportionately affected by COVID, that we should actually make sure that communities of color get more vaccines and faster. And somebody said, yeah, but that's not fair. And I was thinking, wait, that's a definition of equity. We give where people need most. We need to do this. And I feel like a little bit hopeful that at least we're having these conversations. But we definitely need to advocate. We need to advocate in a way where we consciously decide that we're going to, this is something, again, that I've been reading lately, that protect the vulnerable populations and that we empower disadvantaged populations through education. I think that's
right.
Huge.
So getting back to vulnerable populations and disparities and cognitive aging. So we know that there is a connection. There's a connection between health disparities and between affecting organ systems, right, of the body, either directly or indirectly affect thinking, either in the way that you have disproportionate cognitive decline, especially among minorities, or it hits earlier. That's another issue, right? And also there are disparities in getting diagnosed and in getting treated as well. But there are things that people can do, because research has shown that there are the things that people can do behaviorally to try to minimize or reduce the risk, offset the risk. So what you're talking about, for example, is getting educated, right, about health, so that you know what you need to do. Like in my family, okay, I come from a family with a lot of heart attack and stroke. So like I have to know what I need to do in order to reduce my risk, because my risk is higher than the average, than a lot of people's risk. So what do I need to do? I need to watch my diet. I need to do this. Okay, so that doesn't change the fact of my family history, but I'm doing things to lower my cholesterol. That's going to affect my risk. So there are things that we can do. For cognitive aging, it's about getting sleep as well. Sleep is one of the things that people can do. Now, in people who are under a great deal of stress, what happens? They don't sleep. right? Or they take alcohol or other drugs to help them sleep. So again, trying to mitigate some of these risk factors by intervening. So we definitely need intervention on the policy level and on the social level. I mean, this is the source of these health disparities. Then there are behavioral things that people can do to reduce their risk as well, but that takes people having knowledge about what behaviors they're doing that are, contributing to the risk, or kind of like increasing that vulnerability, given that they have pre-existing risk because of disparities. So I think that, there's a combination of things. I certainly, talk about humility, about how do we address this problem. But we need a solutions and programs from on high to have more equity in not only in healthcare, but one of the take-home messages is in not just healthcare, but environmental factors like you were talking about pollution, about how much education people get starting in childhood, about nutrition in childhood, about reducing childhood trauma, because all of these things are part of that stress that goes into the allostatic load, right? That stress response. So this needs to be dealt with on that grand level. And then there are individuals who can say, kind of understand the situation that they're in, try to unpack it, and with the help of their doctor, for example, can try to reduce risk factors for cognitive aging. But that means that you need a doctor, right?
Mm-hmm.
It's that people need to have annual physicals, that they need better access to specialty care, because that's another disparity. So it's a multi-layered problem, but people can empower themselves to help offset the risk, but it's not getting rid of the disparities, right? So that's what we know, is getting rid of the disparities is a mega issue that has to do with our social system.
Absolutely, and thank you for bringing me back to the concrete, Dr. Ercoli, because
It's concrete, so that's what.
no, but that's like something. No, that's really good, because again, I was like thinking, yes, about all this things in the magic wand, and you're absolutely right. We can do some things again, like education, and super important, right? We're speaking from UCLA research. I'm counting on some of my colleagues. I have a colleague who's probably here on this, listening to this, and we need research that is really grounded in communities, that's educated, that the research is educated by the community, so that we can then go back and have interventions that really can impact communities, to try and understand really what are some of the measures that we could take to mitigate those disparities, and how do these diseases really impact Latinos and Black and Native Americans, and how to best address these issues at the more micro level.
Right, and that's part of the cultural humility. Is one of the problems with research, is that often, but not always, it's the researcher who defines the problem. And right, it's also Mother Nature. I mean, if there's illness, right? But it's the researcher who often defines the problem. But we have interventions that, start at the community level by by talking to people and asking, hey, what's important to you? What do we need to address that's pertinent to your, your perspective, your life? And that we need to have more of that to help shape our the researchers' perception of the questions.
Exactly.
We also need to have, researchers of color that have firsthand experience with all of these, you know, many of these issues, because that's, you know, a lot of why people do what they do is because they've been inspired or are responding to their own life situation. And I think that that's really important, to have, so that people know who are the stakeholders here,
Exactly.
and what do they have in common with me.
Absolutely. I think we said we were going to give
Little Q&A.
okay, yeah. So Stephanie Johnson said, I have a just a comment. I'm glad the researchers made a clear distinction between instead of putting all groups together, which can certainly skew data. Yes, that's actually I think more and more, at least to me in my own work, I'm feeling like it's important to let's have this conversation in general, that we're not a I should pick a saying that I can say better than not a one shoe size fits all, that saying.
But it's true, right? And if you think about it, what we also need in our treatment, and this is relevant to Stephanie's comment, is we also need more patient-centered care, because patient-centered care means, you know, you're not a statistic, that the treatment, the intervention is taking into account the total person. So culture, you know, values, and the list goes on, right? So you don't take a cookie cutter and stamp the pattern and say, well, if you have depression, this is your treatment. Right? If you have cardiac disease, this is your treatment. I mean, yes, there are many medications, there are many interventions out there, but there's also very important the psychosocial component, right, to interventions, that we're not just, you know, vessels and cells and hormones and all that. We're total beings. And so a patient-centered approach it really envelops or takes into consideration everything: race, culture, gender, spirituality, right? And so this is very important to treating the person sitting in front of you, whomever that is, but having appropriate treatment, right? And also you want your patient to feel like you're talking about, feeling like valued, feeling like listened to, and also feeling like they are which is important in patient-centered care, they're part of their treatment team, right? It's collaborative.
Absolutely. I actually just came across this term, cultural congruence. We have heard about cultural competence and language congruent, but I like this. It says cultural congruence is care that's customized to fit the patient's own values, beliefs, traditions, and lifestyles. Again, around the theme that 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 not all Latinos are the same, that there's all these preconceived ideas about how we interact with the world, and that we are different, and that those values and beliefs, that they also change, right? That they're fluid.
Exactly.
And they change with the needs. But I think it's important when we have a patient, to your point, Dr. Ercoli, in front of us, that we think about their social context. And when we're doing treatment, when we're doing recommendations, what is the social context in which they are able to really implement this recommendation or not? We're talking about, okay, walk, but can you really just walk in your neighborhood? Do you feel safe walking in your neighborhood? What about your diet? We talk a lot about the Mediterranean diet, and it's not always cheap to buy some of the things in the Mediterranean diet. So we also want to think about, again, the context in which the person is navigating the world based on those social determinants of health. It's important to kind of take a look at the person and understand the concentric circles of systems and oppression that affect them, and then kind of bring it back to the patient. Is I think that the take-home message for me of all this research and this reading and the way that I'm practicing these days.
Well, I want to thank you for being here. I think on that note, that's a great note to close. And I really appreciate you coming today. And this is a conversation that, people are going to be having for a long time to come, and necessarily so. And I hope that, we were able to address, I don't see any questions in the queue anymore. So I just hope that we were able to address kind of some basic definition of health disparities, and really understand that these are things that if you look around you in your neighborhood, if you go over, your life experiences, you can identify many of them that have affected people. But I think that what we're talking about here, it's going to be a complex problem to address, and it's not going to be just at one level. And like you're saying, these are not individual, they're not the fault of the individual. This is built in to our society for many, many, many decades. But we can all do our part to as clinicians, to have our social responsibility to take that into consideration when we work with our patients. Martin, you mentioned, I think this says seeing the patient and comprehending the fear and worry. So true. So true.
And validating that, yes, these life experiences are true and they're real, and we have seen them a lot more heightened in this last year, for many, many different reasons. We're seeing more patients who are re-traumatized and living a lot more, right? Like people of color have experienced so much trauma, racial discrimination, and all.
Right. And we know that the murder of George Floyd has affected so many people, and
Absolutely.
I don't know if you can say re-traumatize. I think it's just added to trauma that, has been there in the middle of a pandemic.
Exactly.
Which is so difficult for every, human on this planet right now.
Absolutely.
Yeah.
So thank you. Yes.
And like Martin says, and it's very important to give people meaning and hope. It's not always about the meds. And that is true, right? Your doctor is a person and you're treating a person. And it's really important for the treatment is the person communication, right? There's no substitute for that. So thank you everybody for attending today. We are here at the Longevity Center. We offer programs. We have a great senior scholars program, talk about education, where you can take a UCLA, audit a UCLA class for half price. We've got memory training programs, and just want to thank you all for being here and spending an hour of your precious time with us. So, and
thank you, Dr. Ercoli, for putting me up to the challenge. You're always looking out for me and always a champion. Thank you so much.
You so deserving of people hearing your message and what you have to say. So thank you, everybody. Thank you, Dr. Suarez. And thank you to our crew and to Christina Domer, who always does such a great job coordinating all these talks. And we'll see you in the new year. Be well, everyone, and stay safe.